everyone, and welcome to the Symptom Media Podcast, Bridging the Divide in Mental Health. I'm your host, Dr. Lindi van Niekerk, and I'm grateful you've joined us for this important conversation. To learn more about Symptom Media's mental health resources, go to symptommedia.com. Our mission here is simple but vital, to bridge the divide between the clinical and the experiential. By fostering dialogue between research, practice, and lived experience, we hope to cultivate empathy and meaningful change in how we approach our work and our lives. In this episode, we're addressing a topic that is quite literally a matter of life and death, the heartbreaking reality of suicide among nurses. Suicide is often cloaked in stigma. For those of us in healthcare, it can be especially challenging to acknowledge our struggles and pain. So how do we break the silence? How do we create a culture where healthcare professionals feel safe to seek help without judgment? Our guests today have walked this path, both personally and professionally. They've dedicated themselves to understanding this crisis and transforming organizational cultures to save lives. Christopher Wojnar is a dedicated psychiatric mental health nurse practitioner and a critical care nurse. His journey into mental health care has been marked by several deeply personal and transformative experiences. Judy Davidson is a nurse scientist in the Department of Psychiatry at the University of California, San Diego. Her research focuses on workplace wellness, mental health, suicide, and suicide prevention among health professionals. Let's dive right in. Chris, Judy, welcome. It's so great that you're able to join us. Where are you joining from today, if I may ask?
I'm coming to you from San Diego, bright and sunny today.
And I'm here in, I think it's almost shorts weather here in Milwaukee, Wisconsin. I think we hit 30 degrees today, so.
Weather that we don't know in California. So I'd like to kick off by asking you both, Chris, Judy, you both are nurses who originally started your careers working in the high-pressured intensive care unit, an environment that's quite demanding, needing meticulous attention, quick decision-making. And I'm wondering, how did this experience shape both who you are and what you care about? Chris, do you maybe want to go first?
Yeah, I think working in the ICU for me has been both rewarding and emotionally intense. It really honed my ability to stay composed under pressure, think critically, make life or death decisions in seconds. But really beyond those technical skills, I think the ICU also exposed me to the unspoken emotional toll that a lot of healthcare workers endure. And that's the constant witnessing of trauma, loss, suffering while suppressing our own, emotions to keep going. And 6 months after starting at my current ICU role, I reconnected with a childhood friend of mine who is also a nurse, and we worked together closely until in August of 2018, he died by suicide. A week before his death, another nurse at our hospital also died by suicide. So between August and December of that year, this is like before the pandemic, 2018, my organization lost around 6 healthcare workers to suicide, and it was just absolutely devastating. So sometimes we're called upon, to follow a path we may have previously intended. Oftentimes, that calling is a result of sometimes some hardship. And what I like to refer to as the meaning-making journey. And I think a theme that people may notice in this episode, that the listeners may notice, is that every person has the option to make the conscious decision to persevere through tough times and turn those experiences into meaningful change. So, after his passing, I heard many people at his funeral say, I noticed this, I noticed that, I should have done more, I didn't know how I could miss that. So that's when I turned to research and seeking answers about nurse suicide, and that's when I found there really wasn't much until I came across Judy's groundbreaking work. And I realized that I wasn't alone in seeing the crisis, but that we lacked a systemic, recovery-friendly, and compassionate response.
Yeah, like you said, sometimes you get more than what you expect when you enter a career in healthcare and work in a specific area. Judy, how about for you? How's kind of starting off in that way shaped you and what you really care about as well today?
Well, Lindy, it's true that I started in critical care, and I am, that is my expertise. I'm not a mental health worker. So I actually took a sideways turn to come into this field and start studying nurse suicide and suicide prevention. What happened was, let me start again. So it's true that I started my career in critical care, and I'm considered an expert in critical care. I was focusing at the time I became interested in suicide, I was focusing on family-centered care and working on the society guidelines, the national standards for family-centered care. And then working as a nurse scientist, I deal with nurses all over the organization, and sadly, in 1 year, 3 different nurses died in my organization by suicide, and they all happened to work in one of the buildings, right? And I thought to myself, this is really odd. This is strange. This has got to be too much. You know, if you were in statistical process control, you'd think this isn't a, astronomical value, 3 in 1 year in one building. This has got to be out of line. So I went to the literature to see how much is too much. Like how much suicide is happening amongst nurses. And I found that no one had studied nurse suicide in over 20 years in the United States. In a couple of countries where it had been studied elsewhere, nurses were at higher risk, but no one had looked at it in the United States. So I cobbled together a research team, and we started looking at the data. My research mentor is Dr. Sid Zizek, a psychiatrist. He keeps me grounded because he is a mental health expert, and he's been teaching me along the way so that I could develop this expertise. So we started with the research, but also simultaneously moved into suicide prevention.
Chris, you used the word calling, and it seemed that there's definitely been a calling on this for both of you. Chris, I want to ask you as well, beyond just being a critical care nurse, I know you recently completed your qualification now as a psychiatric mental health nurse practitioner. And what motivated you to pivot into that direction?
That's a good question. And believe me, I avoided mental health because it's always been something that's kind of just always engulfed me and my family. And so losing loved ones to suicide was devastating. And I've lost a lot of people close to me to suicide. But when my 13-year-old daughter, at the time she was 13, she attempted suicide in 2021, that kind of changed everything. Sitting by her bedside, holding her hand, I realized in the most personal way that no one is immune to suicidal despair, not nurses, not parents, not caregivers. And that moment pushed me to take action. I transitioned to psychiatric mental health care, not just to acknowledge the problem, but to be part of the solution, breaking stigma, advocating for real change, and ensuring that no healthcare worker ever feels alone in their struggles. One of the biggest gaps in healthcare is the lack of lived experience in decision making. Too often, well-being programs, they focus on surface level perks while ignoring the urgent need for comprehensive mental health, substance use, and suicide prevention frameworks. Nurses who have faced these struggles have valuable insights, and really those are the experts that we need to talk to. Those should be the ones that are driving the very policies that are meant to support them. So through my practice, I created my own business and created my own practice, Empowered Psychiatric Solutions, and I'm honored to support health workers, first responders, and those in helping professions. That's kind of a specialty that I have delved into, if you will. And this work is deeply personal to me, and I consider it a privilege to be here for those who spend their lives caring for others. So although it didn't start as necessarily a path that I had going on, but it's amazing how sometimes when you're turning things and finding meaning of hardships, how the paths can kind of open doors for you.
Chris, I really like what you said about the lived experience. It's like the old saying, nothing about us without us, right? Nothing about me without me. And we really do need to hear the voice of the people that have been affected by this to best inform our work. In fact, I've been studying nurse suicide and suicide amongst healthcare professionals, doctors, nurses, pharmacists, since about 2016. And we've done as much as we can studying about people who have died and what we know from death investigations. We've kind of tapped that out completely. We hope in the future to put together qualitative research interviewing survivors of suicide attempts to really find out the true source of what tips people over the edge. What are the factors that we could work on in our prevention models and better inform our work?
Judy, when you kind of first, you explained earlier that you were willing to ask the question, hey, is this okay, what's happening here with losing 3 colleagues? How did other people respond to you wanting to do research on this area? From what I understood, I mean, you wrote this paper called Nurse Suicide Breaking the Silence, and that's really what you had to do. So I don't know if you could backtrack a little bit and just kind of give us a sense of what it was like when you first started doing this work, what existed and what really needed to be discovered.
Well, I'll have to tell you, it was a long road to hoe. I was told no 3 times at work. No, you may not do this. No, do not go here. No, do not study this. No, we don't want to be known as the person, the organization that's had these suicides. And I said, just let me dive into this. I am sure we're going to find out something important for the nation. We're going to learn. This can be helpful to the profession. We can't keep putting this under the carpet, right? So I was told no firmly 3 times before I was told no firmly 3 times before I got a maybe. And then I pushed through all the obstacles towards conducting the work and to get a yes. Part of the reticence was that I wasn't a mental health expert, and why should I be dabbling in suicide not being a mental health expert? I was a fraud in some eyes. But by crafting together the right research team with a pharmacist, a psychiatrist, right, nurses that were involved in substance use disorder, we were able to legitimize the work, move it forward to what it is today. Yeah, but as Chris said, for some reason it was a calling. I don't know why I was drawn so strongly to this topic. I just could not let it go.
And Judy, you bring up a good point. Oh, sorry, Lindi. What I was going to expand on too, just a little bit, was I think even in the research that there's been a lot of silos when it comes to suicide and health workers. You know, historically it was always physicians, you know, and certain types of specialties. When I think what you did with your research team, and I think what other people can do too, is that, you know, it's okay for nurses to study physician suicide. It's okay for physicians to study vice versa. It's that these are things that I think, even through the Dr. Lorna Breen Foundation and others, is that we need to come together to make the biggest impact, you know, regarding suicide prevention in health systems and healthcare.
Well, going back to that original paper, Breaking the Silence, that we published through the National Academy of Medicine, what stimulated that was they put out a paper about physician suicide. And we said, hey, wait a minute, what about us? And so we pitched it to them. We said, if we can cobble together a few case examples as we're putting together our research study, would you consider it? And they said yes. So before we had the quantitative data available for publication, they published those case study reports. And that's what opened the door for us.
Well, I wanted to add that I resonate with your experience, Judy, of being told no. So I was a third-year medical student, and I lost one of my colleagues to suicide. And for some reason, it really made me open my eyes, and I realized how many of my other medical students were facing issues with depression and other mental health challenges. And I ran into the door of our vice dean, and I said to them, what are you doing to help us? And they looked at me and said, well, you can book an appointment with a psychologist through me if you want. And I was just like, that's not anything that a medical student will ever do or say that they have a need. And so that kind of set off this journey to set up this program at our university for students specifically to help them with mental health challenges, but also to do research. And it took quite a bit of convincing to get one of my professors to agree to do research with a third-year student on suicidal ideation, because I wasn't yet qualified enough, according to them, to even be conducting research. But that research also took us to many universities across the country in South Africa to look at an issue. So I think sometimes we just don't take no for an answer, and that's the way to
Well, and
to move things forward.
I must have got lucky because after my friend's passing, I teamed up with a physician to meet with our president of a hospital, and she was absolutely so supportive, and we even established a small group of multidisciplinary group that ended up turning into I co-founded a teammate well-being committee at our hospital that's still in effect till today. So yeah, it's just amazing sometimes though how we push through resistance and we push through no, and then other times things seem like they kind of fall into place. Not to say that everything's been easy and things have always gone that way, because believe me, there are definitely humps in the road for sure.
Well, I'll tell you, after the initial no's, after we started getting the data back from our research findings and started the public journey towards the iterative publications on this topic, and then we went to go expand our suicide prevention program that had been originally launched only for physicians. We went to expand it to nurses because we saw the need through our experiences and also through the data. The chief medical officer, chief nursing officer were extremely supportive because I asked, can we expand our suicide prevention program to nurses given these risks? And they said, well, you're not going to do it just for nurses. You're going to do it for the whole healthcare staff. And now we know last year, one of the first papers was published in the literature about supportive healthcare staff, Dr. Mark Olson's paper, and it's demonstrating that the healthcare support staff are at the same risk as the nurses are for suicide. So we do need these preventive programs for the entire workforce, not just one discipline versus the other.
Oh, and that includes EBS workers, phlebotomists, food and nutrition services. Yeah, that when I saw that too, it just blew my mind.
Well, despite not having, as you said, Judy, the qualification as a mental health worker, I do feel you've become an expert in this area of nurse suicide. And could you maybe just give us a sense of the extent to which this affects nurses, and maybe what are the factors that contribute to them having such a heightened vulnerability?
What we've seen is that we took the data from the CDC, from the National Violent Death Reporting System, and we looked at it over time. We have the entire data set back to when it was first constructed, and the data has been stable enough to analyze since 2005. And we found that nurses from 2005 to 16, female nurses were at higher incidence of suicide than the female non-nurses in the general population every single year. The males for most of those years, right? Then recently, just in December of 2024, we published an update to that paper. And now more and more states have been contributing data to this voluntary reporting system through the CDC. And we think the data is a little more stable now. And it may be telling us the real picture. And now the female nurses are consistently higher incidence of suicide than the general population of female non-nurses. And it's important in suicide work to match female to female, male to male, because there's a disparity in the proportion. Men complete suicide at a 4-to-1 ratio to females. And nursing is a female-dominated profession, so you have to do all this math with the denominators and compare female to female and male to male to make it all work out right. Okay, but the females now between 2017 and 2021, that's the most recent data we have. Okay, the females are at higher risk than the females in the general population, but the males are no longer statistically significantly higher. But every death counts, right? This isn't a contest about who's got the statistically significant number versus not. Men in nursing still die by suicide. So we cannot forget our the male counterparts. So the females up to 40% higher than the general population of females in the general population. So what are some of the important things to look at? Well, we found that nurses have more known job-related problems prior to death by suicide than non-nurses. So the people that investigate every case of suicide have about 35 coded elements in the data that they yes, no, yes, no. One of those is, was there a known job-related problem prior to death? And the answer is more often than not yes in nurses, okay? And then of those job-related problems, this is really the troubling thing. I thought I was going to see things like exposure to death or work compression or burnout or things like this. But what we found from reading the narratives is that the majority of those nurses, the vast majority, over 90% of those nurses who had job-related problems, the problem was either they had lost their job or were in the process of being interrogated and possibly losing their job due to several big factors, either musculoskeletal injuries, not being able to work any longer in the job due to illness or injury, mental health issues that were out of control, pain that's not controlled, and then substance use disorder. And the discipline associated with substance use disorder is a very common occurrence in these deaths by suicide where the nurse had a known job-related problem. We think, because of what we've seen in the data, that we need to start reimagining, rethinking, and testing new best practice strategies for how do you work with nurses who are identified to have the treatable disease of substance use disorder. And currently, until now, we've been treating this as a criminal event, right? Focusing on the criminality of the event, coming to work impaired, possibly diverting substances from the workplace, instead of focusing on treating the condition, the treatable mental health condition of substance use disorder.
Yeah, and I'm really excited that we'll have a whole episode where I think we're going to dive into that, thanks to you really raising the importance of that area of substance use and how that affects nurses. Chris, Judy mentioned several workplace factors and how nurses see their jobs, but I'm wondering if you could delve a little bit more into some of the personal vulnerabilities or circumstances that could really increase the risk for nurses.
Yeah, nurses we're driven by purpose, right? I mean, and responsibility and perfectionism. And I think perfectionism is a huge one. So qualities that both make us exceptional caregivers, but they also increase our risk for mental health struggles. So the profession almost reinforces the emotional suppression, right? Training nurses to prioritize patients over themselves, stay composed in crisis, push through exhaustion, because that's just what we do. Social identity theories, which I've learned a ton about. Before I didn't know anything about, but now being a psych MP, but it makes perfect sense, and it explains how uniforms and professional culture, they reinforce this mindset. The moment that we put on our scrubs, we then embody this caregiver role, and often it's at the expense of our own well-being. And the expectation is always to be strong, and that oftentimes makes it difficult for us to acknowledge struggles and let alone seek help. So perfectionism adds to this burden, leading to internalized shame, self-doubt, sometimes even like imposter syndrome too, which I think is also a big thing, especially for nurses who are just starting out. But over time, this stress continues to accumulate and increasing the risk of burnout, moral injury, and then subsequent suicidal ideation. There's a lot more nurses that have survived suicide attempts and are surviving with suicidal ideation that, have not died by suicide. And, compounding this, I think, is the culture of silence we have in healthcare, where speaking up about mental health is usually met with stigma, or even disciplinary action. I've heard nurses, being in fear of being seen as weak or incapable, and preventing them from reaching out for support. And this is a profession where struggles are often taboo, and seeking help can almost feel like a career risk. Ultimately, I think the very qualities that make us exceptional, empathy, resilience, self-sacrifice, can also make us vulnerable. And I think we have to shift the culture so that seeking help is seen as a sign of strength, not as a liability.
Yeah, at UCSD, Chris, we developed a process for suicide prevention called the HEAR program, Healer, Education, Assessment, and Referral. And through this, what we've done is because of this fear of the career limiting aspect of admitting that you've got a problem, right? That we use an anonymous encrypted screening process for mental health screening so that people are allowed at any time, and we're sent a message. Everyone is sent a request at least once a year to do the screening as a matter of self-care. And you do this screening, and the screening profile that we partner with the American Foundation of Suicide Prevention, that ISP interactive screening program. The mental health screening encompasses many different aspects of mental health problems, sleep disorders, anxiety, depression, substance use disorder. It does include burnout as well as the mental health issues. In any case, when someone does the screening, it goes through encryption and it's scored. And those that are like moderate and high risk, they all go back to a therapist who connects with the person through the computer, and neither person knows who each other are. So there's all this psychological safety in it. You can do this very safely without any risk to your job or license or, your identity as a nurse. And you can even be referred into treatment anonymously. And we think the fact that we push it out to people, not wait for people to come for help, and we also have this built-in psychological safety because you can remain anonymous is why it works. And we just, last month, December 2024, we published a paper on 14 years of this, and we put over 1,000, we've been able to transfer over 1,000 people into mental health treatment through this screening program. So unfortunately, there is still stigma around this whole issue of help-seeking behaviors, but this gets past that barrier of the psychological safety. But I do want to say, this was a long story to get to this point. But the point I'm getting to is by doing this screening year after year and endorsing it and encouraging it year after year, plus some extra group debriefing sessions that we do using the same therapist team, we've been able to kind of erode at that stigma against help-seeking behavior. And we're seeing more and more employees bypass the anonymous screening and just dial in for help directly, without having to remain anonymous. So we're seeing a big shift in the organization to where people are now open to seeking help for mental health problems.
And I think what I love so much about that, what I love so much about that too, Judy, is we're not relying on people to always reach out, right? I mean, we're finding a way to compassionately, safely reach in and offer and guide, not to force or coerce, because I think that is not the right way either, but to really reach in and to connect and show that you care. I think that's huge.
Yeah, normalizing the behaviors, right? Every year you're sent a message, have you done your screening yet? Do a screening this year, this is for your own benefit. And I'll tell you a case story about why I know that this whole process worked, and it works and is working to reduce stigma, and it's working to inform our healthcare workforce of what to look for. One day the phone rang at my desk, and a nurse was on the call, and she said, "Judy, how do I get a hold of one of the HEAR therapists?" And I said, "Why?" And she said, "I'm working with a suicidal doctor today. I'm working with a suicidal doctor today." And I said, "Oh, okay, let me get you the therapist's direct phone number." And I did, and they connected. And long story short, the doctor came out of service, went into treatment for depression, and eventually came back into the workforce once treated and stabilized. But that night I called the nurse up and I said, of course, if you had gone through that day, you would need a debriefing, right? It would be good to debrief. But I was curious also as to how she knew this doctor was suicidal. And I said, "Hey," I said, "tell me more about what happened. How did you know he was suicidal?" And she said, "Well, I just saw him getting more and more despondent day after day." and he wasn't like himself. And I'd been to one of your talks, your grand rounds on this project with suicide prevention and your suicide research. And I remember you saying to, the audience, if you suspect one of your colleagues might be suicidal, you have to ask the question directly and say the words. And I did. I remembered I said the words, "Are you feeling so badly about yourself that you've thought of killing yourself?" And to her surprise, he said yes. Okay, so she had heard those words, remembered the words, said the words, and then she said to me, "I also had done the screening myself, so I knew the symptoms to look for because I had done the screening myself. So I know the program works on many levels." That nurse saved a life that day, right? And the screening program helped her be prepared for that moment in time when she was faced with a colleague that had problems.
I'd like to ask you both. I mean, this seems like an amazing example, and you've put that in place, Judy. Chris, you also mentioned you had a colleague that committed suicide. And what was your organization or your hospital's response to that? I'm curious. Is that as supportive? Do all people have that supportive response, or?
Yeah, and I'll be honest. I think I hear firsthand from nurses across the nation about a lot of these things that happen, whether or not it's how organizations are responding to mental health needs of the nurses and the teammates, and I really do want to say that that is a great exemplar that Judy's been sharing, and I think that that's something that could be spread across the nation, and it really, I think, needs to be. Because it's not something that's everywhere. And a lot of times after a nurse discloses mental health challenges in the workplace, or they attempt suicide, or end up with taking a leave of absence, or if they're actually referred to an employee assistance program, sometimes what may happen is something called, and what I've heard nurses have to navigate, is like a fitness for duty process or policy. And I think what I've heard from a few leaders and what they may say is that, well, at first, nurses may resist or be fearful, but then at the end of the process, they thank us. Or I've even heard certain leaders even say, well, you can't dissuade a leader from pursuing some sort of type of punitive or corrective action in fear of a nurse dying by suicide or hurting themselves. And I think, to the first comment I have to say is that how do nurses make it through that initial phases of, if you're navigating a fitness for duty policy or whatever it may be, how do you make it through to the point where you are able to actually make meaning of the situation? Because what Judy's research and what the research has shown is that when nurses do feel like they have a fear of job loss, they feel like their world is ending. There's no way out. I'm going to lose everything I've worked for. I don't know who I am without this job, right? And I think those are the things that we have to help nurses and other workers to navigate, to support them, to hear them compassionately. And I think the big thing is it's a lot of fear-driven things that I think organizations that I hear how they respond. It's a lot of fears in like, well, we can't ask them about their mental health because that's a violation of ADA, or we can't take this route or cross this line because of liability concerns. And I think what it ends up turning into is that a nurse sits down and you're sitting down with them and you're basically told, call EAP. And I think that is probably one of the most disingenuous and probably the worst thing that a nurse who's struggling or navigating some sort of corrective action or even like a hardship, to hear that, especially if the person who you're talking to doesn't take the time to first validate, compassionately listen, and then you're just being told, call EAP. And I think too, what I've also seen as well is that nurses who do take leaves of absence or are either forced to take a leave of absence for treatment, they tend to exhaust their PTO, and then you face financial ruin. So if substance use is involved, they have to report themselves to the Board of Nursing, or should report themselves to the Board of Nursing, endure public exposure. They have to comply with costly restrictive programs, more punitive than restorative programs. And I think, the fitness for duty evaluations are meant for safety, just like a lot of these things are. I think they're meant for safety, but the unintentional punitive undertones often create this culture of fear, deterring nurses from seeking help. And, this is why I became an ambassador for the Dr. Lorna Breen Heroes Foundation, and that's to integrate nurses' lived experiences, the stories that I've heard, through the Wisconsin Nurses Association and through my work, is to hear what nurses have said and these stories, to be able to share these stories and allow them to have a voice and to integrate these lived experiences into things like policy reforms, especially in Wisconsin. And we've done just that. So I think there's a lot of work that we can do from an organizational standpoint of how we respond to not only mental health, but also suicide, whether or not it's a suicide attempt or a death by suicide in the workplace. As Judy mentioned, sweeping it under the rug. And again, I think that's fear-based. How do we do so in a way that we don't want to cause contagion theory, which, believe me, contagion theory is real. It's alive and well. How do we balance this to where other workers and colleagues don't feel like the organization doesn't care or is just trying to sweep this under the rug? And how do we move forward to healing and recovery? And again, allowing nurses to not have a fear of reaching out for help and seeking help, and ultimately losing everything if they do so.
Yeah, I'd like to respond to a few things. Boy, Chris, you got a lot in there. I should have wrote down a big list of everything. But the organization's response to someone in the realm of discipline, right? We do need to restructure our leadership training on how to bake in psychological support to nurses who are struggling. And then I think we need to take some of these situations, we need to take a PI lens to, performance improvement lens to, and really dig back to root cause of the problem, right? What I'm finding in death narratives is sometimes diversion of medications drills back root cause is chronic pain that was prescribed a narcotic, and the pain was never controlled, and then the narcotic use gets out of hand, and once the person forms the addiction to the narcotics that were prescribed by their doctor, they start to make bad choices at work and end up diverting. So tracing back root cause, it was uncontrolled pain, right? And that's how do we deal with a person with uncontrolled pain? Is discipline the best answer for that? I think most of us would say no, right? That this was a good person trapped in a bad situation and had a undertreated health condition. And if we go back to PI principles, going back to root cause, we would better treat the pain for this nurse, right, instead of enact discipline. Okay, and we do need to report, of course, theft of narcotics must be reported through by the pharmacy to the DEA. Of course, that has to be reported. But what do we do for that nurse in the meantime? You mentioned that if they go on leave of absence, they eventually deplete their store of vacation and sick time. Well, that's a whole lot better than being fired. I would take leave of absence and use up your time before the over firing somebody automatically, which unfortunately is what happens in the majority of cases in the profession of nursing, not in medicine. But nurses commonly are fired for diversion. Then they're left without the resources at all to be able to get the treatment they need for whatever caused the problem, right? So choices. Yes, depleting your resources eventually because you only have so much time off, that's one thing. But to be fired, you're left out there on your own, twisting in the wind without you end up in financial despair, destitution, and what we read too often in the death narratives is suicide. So there's that. Then so I think our leadership team, the risk managers, HR, and the nursing leaders, we all need to reframe discipline, to think back to investigating root causes and treat root cause before going directly to discipline and disciplinary action. right? There's a lot of other, there's many treatable conditions that nurses have that can be treated without firing the nurse. We're not widgets. We are not replaceable. We're humans who sometimes have complex medical conditions that need to be treated. And if we focus on treatment first approaches, can we salvage these lives, right, instead of throwing them away? That's important. Now, if somebody dies by suicide, what should be the organizational approach to that, right? And here, oftentimes, organizations, due to not feeling comfortable with the situation, do sweep it under the rug. So I think, again, leadership training needs to include how to deal with this. How do you deal with a suicidal employee, an employee with suicidal ideation or behaviors? How do you deal with fact if an employee dies by suicide? Do you have an organizational structure and process to support the rest of the team through the grieving period? Sweeping it under the rug will erode organizational loyalty because the balance of the workforce will be left feeling unsupported when they know what happened. Trying to keep it a secret from the employees does not work. Okay, so the employees will find out. It's important to really work through this as an organization and offer grief rituals and time off from work for the people that were affected most deeply by the situation or the person. That person who died, their best friends on the job will likely need time off. A little caveat to this whole thing is the manager. The manager has to do a lot of work at the death of an employee. They have to organize the termination of the employment with HR, post the new position, fill the holes in the schedule, return the employee's belongings to the family, deal with the family, the last paycheck. So that in addition to making sure that the psychological support is offered to the balance of the team. So the manager has a ton of work. And what managers need to expect is they may have a kind of like when if a elderly parent dies, the oldest child usually is left to do the estate, to take care of the estate, the bills, the bank, all of that work, the paying for the funeral, organizing the funeral. And then the oldest child has this delayed response and ends up grieving a month down the road when everything's kind of settled. And the managers in a healthcare organization often have that same experience where they have to shore up and get all this work done for the staff and everything around them and the job to keep business operations going as usual. A month later, they're going to have a letdown, might need time off themselves and a little extra support on a delayed cycle from the rest of the organization, the rest of the employees.
Well, and that too, I think we touched on a little bit upstream, which is, when you say upstream, it's how do we try to find the root cause of like what is happening. And then I think another thing that comes to mind is a phrase that's commonly said, in the suicide prevention world is, postvention is prevention. And a lot of organizations, healthcare systems, they have nothing in place, right? And I mean, this is both support for leadership, administrative support, robust postvention toolkits, or things that can kind of help assist in the process. A lot of times it's talked about, maybe even if there are some postvention toolkits or postvention resources out there, it's talked about once, and then given the turnover of nursing leadership, a lot of times it's ultimately not talked about ever again. And then it happens, and then you're left thinking, okay, well, what do I do again? So I think even from the workplace suicide prevention guidelines, and I've had the honor of being involved with that too, I think what we also have to talk about, and what both the International Association of Suicide Prevention's Workplace Special Interest Group, in addition to the National Workplace Suicide Prevention Guidelines, what they really are calling out is work-related suicides. And I think this is what we have to start calling them as, is that if we're not just talking about correlating factors anymore, we're talking about causation. We're talking about things that are significant contributing factors to a nurse dying by suicide that are related to the workplace. And I think given that terminology, I think obviously a lot of organizations are going to be may quiver at that a little bit and not like that, because usually when you do term something as workplace related, that we have to start thinking about then compensation for such, and how can we really start to look inward at changing our processes, because the things that are happening in the workplace are causing suicides.
Chris, you brought up
Chris, sorry, Judy, sorry, I want to just jump back in here, because I just want us to come back to that sense of the lived experience, because you both highlighted that in the beginning, that it's really about bringing the personal experience into that, so that I think people can understand these recommendations through that lens. And Chris, I know you've had a personal journey with suicide, and you've really challenged those expectations in medicine, where it says, when healthcare, we shouldn't self-disclose, we put on our armor, like you said earlier. How have your colleagues and patients responded to you being so open to speaking about your experiences? And how do you share your story with them?
I had to learn, and the first time that I shared my story was after my friend passed, and I worked with a psychiatrist at our hospital who sat down with me and actually filmed me and her kind of doing an interview in like how I would share my story. And me being a suicide attempt survivor, and to persevere through the hardships that I've gone through, my first time sharing my story in a professional setting was actually to, like, I think it was 84 medical residents at my hospital in our auditorium. And sharing my lived experience, I think, has been both deeply personal and also profoundly impactful for me. It's, there's this longstanding expectation that we have to maintain this emotional distance, right? As I talked about before, we put on our uniforms, and that immediately kind of closes us off. And we have to do that because we have this misconception that we have to do so in order to be there for our patients, and we can't show weakness, and we have to be strong. But I've found that being open about my journey has actually helped break down barriers and create genuine human connections. Maybe I'm not saying that I'm like the major contributing factor to this, but I've noted actually in my own department too, in the neurological ICU intensive care unit, is that we do have a department where people do talk about their things that they're going on, they're struggling. You start hearing people talking about, well, hey, I have ADHD too, or I have this going on and I'm on these meds. Oh, what dosage are you on? I'm on this dosage. Like, things before that would never even be talked about before, I think are now starting to be talked about. And I don't look at my colleagues any differently than anyone else. Just like when I share my story, you do have to, there are obviously times when you are thinking about sharing your story, you have to think about where you are in that space, your self-care. What do I want to get out of this story? That actually led me to, when I was trying to investigate like how to safely share my story, that was actually when my daughter was going through some tough times. And I wanted to share with her, like, hey, dad's been through some of these things. I don't know exactly what you're going through because you're a teenage girl and I was a teenage boy, but, these are kind of some of the experiences that I've been through. And I came across United Suicide Survivors International, which is a nonprofit organization that actually offers storytelling courses. And I leveraged those storytelling courses, and eventually down the road I ended up becoming a board member. But I think for the most part, many colleagues have expressed gratitude, telling me that hearing my story has made them feel less alone in their own struggles. Some have even shared that it gave them the courage to seek help for the first time. Now, not everybody has the same experience, so I'm very blessed because I've also heard from other people that when they share their stories that they've been treated differently. And this is the reason why my goal and my mission has been to break that down. And even the patients too, if there is a selective time where I do happen to self-disclose a little bit about myself, I'm always thinking about obviously how this is going to impact those I serve. But that when people know that their provider truly understands what it's like to walk through darkness and come out the other side, I think that builds trust and hope. And at the core of this, like I mentioned, is ultimately normalizing vulnerability in healthcare, and that speaking openly, I hope to challenge that stigma, reinforcing that reaching out for help is not a sign of weakness. It's a sign of strength, and that it makes you more compassionate, understanding, and an effective clinician to have lived experience. And I think that's why, and the things that I've gotten out of sharing my story and the opportunities that I don't think I would be here today if I hadn't have started to share my story.
Well, I know a little bit about your story, but maybe just for the sake of people listening, would you maybe share a little bit of that journey that
Sure.
you've had?
Yeah, when I was 5 years old, my grandfather died by suicide, and that was in 1990. Now you kind of age me, so I'll be 40 coming up in April. But in that moment when I was 5 years old, I never knew that anybody could take their life, and that's where, from that point on, I think that was a pretty traumatic experience for me, like an adverse childhood experience, as you will. And I think that was the first moment that, hey, somebody can actually end their life was actually implanted kind of in my brain. I went through some other hardships when I was younger as a child, but then I started in high school and I started to gain the attention of girls. And I kind of based my happiness on relationships. And because I didn't really have any self-value and self-worth, subsequently, after breakups, I would feel like I had no purpose in life and that I was worthless, and that just continued to resort to these. It almost was like a coping skill for me to attempt to end my life, because I think a lot of people, they are in so much emotional pain that they see no way out, that they just want the pain to end, and this is the way to do it. And I had this thought in my head that death was better than living. And I had that thought so deeply ingrained in my head that after my fourth hospitalization for my fourth suicide attempt, and each suicide attempt, I barely survived. There were circumstances that would kind of thwart it, or I would be found and I would survive. There was a I can't even remember if it was a psychiatrist, but it was almost like a voice from above, because I don't even remember if it is a therapist or a psychiatrist or another person who I was in group with maybe, said, "Chris, how do you know that death is better than living?" And in that moment, I said to myself, I said, "I don't." And I said, basically to myself, I said, "I don't know what happens if I were to die or end my life. I don't know what would happen." And that kind of led me down a journey and a pivotal moment where I started to tell myself, okay, you've survived this. Maybe you're supposed to be here. Now let's start doing something with it. And that really started the journey of me going to firefighter school, trying to be a firefighter, and then ultimately going back to school for nursing. And nursing's ultimately been that purpose for me. And now, even being a psych MP, I think it's allowed me to take my past experiences, my past struggles, and to use them as ammunition for persevering. It's kind of set that, I guess, reference point for suffering and pain. And I think one thing, when I talk about a reference point for suffering and pain, I think when you do persevere through some of the toughest things in your life, I think that gives you strength to say, I can, if I did it then, I can do it again. And I think that's what keeps me going sometimes, is referencing that past pain and that suffering, and also trying to find meaning in the hardships, because I think what I like to tell people is that when you're riding in the car and the road is bumpy, all you can focus on is why my butt hurts so much, right? It's not until you make it through and maybe the road is more paved and you still have some potholes here and there, but you can look back and you can say, okay, that's the reason why that road was like that. Now let's see how I can maybe tell somebody on how to fix the road, or create a different path, or tell somebody, hey, don't take that route. And I think that's been the biggest thing for me, is being able to take past pain and turn it into purpose, not only for myself, but also for others.
Chris, thank you. I mean, I think it's just really helpful not to make assumptions. And like Judy corrected me earlier on the language matters, and understanding someone's experience is so valuable. So thank you for sharing.
Well, and what I like to tell people too is that, because I give the same talk to new nurses at my hospital every single month. So I talk to about 50 new nurses every month, and the presentation that I give is on nurse well-being and suicide prevention. And I've been disseminating, Judy's work and the research findings since really they've been coming out. And I've had the honor of delivering this presentation, and I stand in front of everybody. I may not tell the deep, comprehensive version of my story that I shared just now, because I only have a half an hour to talk to people. But when I tell people, I say, would you ever thought in a million years, looking at me, that I have been through the things that I've been through? And I think that's even a deeper lesson, is that when you do look at people, you can't just assume what they've been through just by seeing them.
And there's just so much more to us than just the uniforms we wear. And I think it's really powerful. Judy, I know you and Chris have teamed up, and I'm curious, kind of doing the research, but coupling that with a lived experience. How does that change the reaction you get to this work? And how does that really help with the advocacy of the message?
And Judy, before you answer, I just wanted to say, I think what happens is that I can sit here and I can say, I'm a dad, I'm a husband, I love concerts, I love music, I love traveling, I love all these things. But then once I say I'm a suicide attempt survivor, it seems like that's the only thing people hear. And I just want to say that there is so much more than people than their hardships and their past experiences. Like, I am so much more than that sliver of my life, which is very informative. But I am so much more than just that experience. So I think that's also an important note too. But yeah, lived experience and advocacy. I think the Dr. Lorna Breen Hero Foundation actually is a great advocate for that as well.
Yeah, so let's focus on the Lorna Breen Foundation for a minute. So the Lorna Breen Foundation began after COVID, when Dr. Lorna Breen, who worked in New York in the epicenter of the pandemic at that time, died by suicide, and her family later attributed that death partly to the fact that she was afraid to seek mental health treatment because of what the Board of Medicine might do with that data if they'd known she had sought treatment, right? And I know through our suicide prevention program at UCSD, that people do tell us in that program that they're afraid that anyone will find out they went to treatment because the licensing questions and even credentialing questions within an organization in the medical staff office, all the APPs that are credentialed through the medical staff office are affected by the credentialing questions. They often have intrusive questions about your past mental health problems. And ask even sometimes about your medications or your diagnoses, which all of that is against the ADA. It's against the law to be asking those questions, but the boards of medicine, nursing, pharmacy, and even healthcare systems in the credentialing offices often ask these questions that they once wrote for good reason. They thought they were protecting the public from bad people by writing these questions and figuring out who's good versus bad, and then limiting the licenses of those who were quote unquote bad, right? So the Lorna Breen Foundation started to kind of change this, to shift the mindset and get the boards of medicine to stop asking these intrusive questions, because they do stigmatize against help-seeking behavior. They do more harm than good, right? So instead of protecting the public, they're getting nurses, doctors, pharmacists with mental health concerns to go underground, maybe even self-medicate instead of going for treatment, because they're afraid to get the treatment and then disclose it when they have to renew their licenses. So the Lorna Breen Foundation focused initially on physicians because, of course, Dr. Lorna Breen's a physician. And I found that Corey Feist, the leader of that movement, was speaking to this issue at many of the events where I was also speaking. And so I said to him one day, Corey, can we sit down? I need to share with you the nursing data. The nurses are at least as high a risk, if not higher, than the physicians. So could you please expand the scope of your organization to include the profession of nursing? And he read our work, and he did. They did expand. They have a whole project team now within the Lorna Breen Foundation focused on the issue of the licensing and credentialing questions in the profession of nursing, trying to engage each of the state boards of nursing to amend their questions to be less stigmatizing against help-seeking behaviors. And he set up an entire advocacy campaign. You can use a QR code that we'll make available at the end of this program, that if you scan the QR code, put in your zip code and your name, it'll bring you to your state board of nursing with a templated letter to ask them politely to change the questions and eliminate those stigmatizing questions. So that's about the Lorna Breen Foundation. You can do the same thing with the credentialing. If you happen to be a nurse practitioner, midwife, nurse anesthetist, and you're credentialed by the medical staff office in your agency, and there are questions on those credentialing questions that are stigmatizing you, they've got a toolkit for you that you can download bring to your medical staff office, ask to set up a task force to look at the questions and revise them. Any healthcare system that cleans up those questions can submit to the Lorna Breen Foundation for public recognition, and you will be publicly recognized for helping to save these lives by decreasing stigma.
Chris, Judy earlier referred to the story of the nurse that was willing to have the conversation with the doctor she was working with, who she thought may have suicide. And again, as a suicide survivor, what guidance would you have of how one can have that crucial conversation? Because I think that's such a difficult thing for people to do. They may be aware of it, but just to have that courage to have that conversation with a fellow colleague and staff member, how would you give guidance on that?
Chris,
Well,
why don't you go? Chris, why don't you go first, and then I'll talk about some resources available publicly.
Yeah, absolutely. Yeah, so when what I would say first off is that to know available resources before checking in with a colleague. I think the worst thing that can happen is that if you are entering into a conversation and somebody does disclose mental health challenges and then you don't know how to refer them or where to refer them, I think that can be a very tricky thing. So just like self-care, the resources should be identified and practiced before a crisis arises. And the goal isn't to fix their situation, but to create a safe, non-judgmental space, I think, where people can feel seen and supported. Now, many nurses, they hide distress behind professionalism. They push through exhaustion, insisting they're fine, right? How many times have you heard, I'm fine, or I'm okay, when you knew that it wasn't true, right? So I think I've said I'm fine, or hey, how you doing? Oh, I'm okay, and then just moved on. So I think when you hear some of those things, you have a choice, and you can say something like, oh, I hear you're saying you're okay, but you don't seem like yourself. If something's weighing on you, you don't have to carry it alone. And I think if they're not ready to talk, that's okay. What matters is that they know someone cares. If they do open up, listen without judgment or rushing to solutions. Again, I think the worst thing that could happen is like if somebody starts telling you some very personal things, then you just say, well, here, call EAP. that can seem very disingenuous. So you just want to make sure to listen.
What is EAP? Just for people who may not be listening from different places.
Yeah, so EAP, we talk about it like it's natural, the thing. So EAP being an employee assistance program. So these are programs that organizations can invest in or sometimes develop on their own to offer resources for their employees. It could be mental health, it could be financial health, it could be a lot of different resources. So employee assistance programs. So when somebody is struggling, to just tell them, oh, hey, well, that's nice. Here's employee assistance program. Call them. I think that's where they feel very alone, isolated. And I think, if they express distress or suicidal thoughts, the big thing is to stay calm, validate their feelings. I can say things like, I can see that you're carrying a lot. You don't have to go through this alone. I'm here and we'll figure this out together. Encourage seeking help, and if needed, offer to connect them with peer support, the employee assistance program, mental health professionals. If there's an immediate safety concern, you want to stay with them, remove lethal means, and involve appropriate support while ensuring they feel safe. The most important thing is to show up, listen, and remind them that they matter. And the simple act of connection can be life-saving. And I think it took me about 6 years to offer and to establish a standardized response for health workers who do encounter somebody who is struggling, to actually implement that within the organization that I'm affiliated with, and also within others. And I think these are simple things that we can teach people to help them to be there and to show up and to listen and to validate without rushing to trying to fix the problem.
Yeah, Chris, I couldn't agree more.
And valuable. Thank you.
Yeah, I couldn't
Judy.
agree more with having the phone numbers ready. So what I strongly advise is that you open up your phone, put a new contact in, call the contact crisis. Then within that contact, put the 988 suicide hotline in there. Then also look up your regional suicide hotline, put that number in there. Then look up your employee assistance program phone number. Every health system has one that employees can dial into to get treatment, but that's not for crisis. That's not for like somebody with suicidal ideation. That's somebody with mental health concerns that hasn't gotten to that point, right? To be able to find treatment options, the EAP program phone number. So you've got the 988, the regional suicide hotline, and the EAP phone number in your phone for crisis. If you work in a place that might have an active chaplaincy service, they're often very helpful. You might want to add that one in. So all used for different situations, okay? But then you have the phone numbers at the ready just in case you need it. You're sitting in the room with somebody that you think might be suicidal, they're actively expressing ideation. At that point, you don't leave them alone, just like Chris said. Stay with them till they're connected to care, okay? And care would be depending on where you are. Are you in a hospital with the ER right downstairs, right? At which case, how can we get them there privately? Can you employ the help of the house supervisor to secure a private place for this person so they could save face and dignity while seeking care? The things to say to somebody in that moment to get them to yes, using motivational interviewing skills, right? To be able to get somebody to agree that yes, it's their idea that they should go for treatment. One of the things you can say is, I'm really concerned about what you told me. I've heard you say that you're despondent. I've heard you say that you're in despair. I've heard you say, and repeat back whatever you heard them say after being empathic and listening to them. So you've got all of this, you've repeated back, you say, but now I'm really concerned. Don't you think this is a little bit more than a friend can handle alone? I'm your friend and colleague, but what do you think about getting more support to help you through this process, through what you're going through? And hopefully they'll come to yes at that point. Once somebody comes to yes, then it's, okay, what should we do? Do you have a care provider that we could call on the phone together while we're here? Right? They might already have a psychologist or psychiatrist. They might have a therapist that they could contact for emergency. If they're not already connected to care, should we go down to the ER? I can make sure we could get you down there so people don't know what's happening, right? If you're not at an ER, you got to have plan B. But think to yourself about your workplace. Where would you help somebody get connected to care? And an active suicidal threat, then of course dialing 988 together and put it on speakerphone, right? Do you think we could call 988 together to have them connect you to the care you need for this right now, right? And talking them through the process. Now, to learn how to do this and practice it, we've started a program at UCSD, given how frequently this comes up for managers for leadership training. And it's a 90-minute program where they actually have a script of an employee expressing suicidal ideation and then practice their response in breakout rooms and practice the words out loud so they'd feel comfortable if they had to use it over time. Another way for you, the audience, to do very easily is search these words in your browser. OSU for the Ohio State University, OSU suicide video. You'll come to a screen with 6 different videos made by my colleague, Dr. Sharon Tucker, and they're each less than 6 minutes long. They're 5, 4, 3 minutes, each one of these scenarios, role-playing how to talk to somebody with suicidal ideation or behaviors. If you watch just a couple of those videos, you'll be able to do it yourself. You'll feel like you're confident in approaching the bench on this. And why am I stressing this so much? Well, recently we did a talk at a AONL, the big nurse leaders organization. There was 143 people in our room, and we were talking about this leadership training that we developed at UCSD. Christina James and Rachel Accardi are the 2 leaders of that program, not me. But we asked the audience, how many of you have had to have the talk with an employee who was expressing suicidal thoughts or behaviors? And over 60% of the audience said yes, and another 14% said no, but maybe they should have. So that's like 75% of the audience said yes, okay? This means you're going to need this skill. So please go to the OSU videos, OSU Video Suicide, you'll find them, and watch a couple of those little videos. Practice it yourself, the skills, think about your workplace. Where would you help somebody get connected to care, or do you need to do it through 988? And make the crisis phone number in your phone so that you're ready when the time comes.
Judy, I also want to ask you, I thank you so much. This is such valuable guidance for people. I want to ask you, how do we help people, especially other health workers, if they've lost a colleague to suicide? What can organizations do? How do we support workers through their grief? You've earlier said that the most important thing is not to pretend like it never happened.
Right.
And
yeah.
What advice would you be able to, or what suggestions would you have of how we support health workers?
We've published a couple of articles on this with point-by-point, steps to take when an employee dies by suicide, what can be done to help. And the most important thing is to have rituals for grief processing. Make sure that there's a memorial or something like it so that employees can come together and process their emotions, know that they're not alone in their grief, and start working through those emotions together. So I think that's number one. Do not ignore it. Don't hope that it's just going to go away on its own, and provide opportunities for employees to get together and process the grief. There's a little wrinkle in this when the family doesn't want anybody to know it was a suicide. And if they tell the leader of this, it's usually either the manager or the crisis counselor that's leading the effort at helping the organization through one of these events. If the family says that, we do have to respect it. But in all honesty, the word will get out and the staff will know. And you really can't ignore the fact that it happened.
Chris, what have you found in your experience with the colleague that you lost, and how did other people around you process that, including yourself?
Well, I've had a couple of experiences where exactly that happened, where we knew it was a death by suicide, but it was not talked about that way, and I think that can be more painful than sometimes and more traumatizing than the actual death itself, especially because then I think you're just basically like compounding on top of grief, and you're adding these unnecessary things. Now, so I think there has to be a balance, and it's difficult. These are very complex situations. These are very tough, sensitive situations, and I think there has to be a balance where we can, honor privacy while also honoring healing and moving forward for those who knew the person. And so I think for me, what I've experienced, for one, at my friend's funeral, like I mentioned, is that a lot of people were definitely feeling very guilty, and they ultimately felt like I should have done more, myself included, because my friend and we went through similar experiences when we were younger. He went into the military, I went to firefighter school. Both of us ended up circling back and becoming nurses and then working at the same hospital together. And so I think there's, even for myself, there was questions like, man, how come he's not here and I am? And then on top of that, was also the things that I was hearing from other colleagues, and even collaboration with his leader, who was tasked with disclosing and sharing with the team that he had died by suicide, and he was no longer with us. And I remember that leader in particular, who I became very close with, telling me that was probably one of the most traumatic things he's ever had to do in his tenure as a leader. And so I think those experiences and how we support, I think that what we can do is we have to listen to those who are grieving. We have to listen to the lived experience of the people who are experiencing this, and try to find what is the most meaningful thing for the team, what is the most meaningful thing for every individual. Might be different. Some people, they don't necessarily want to be involved with a ritual, or some people, they don't want to be involved with a memorial, or then you have some people, at least in the suicide prevention professional space, who think that you can't glorify or memorialize suicide death because then that equals contagion. But then there's the other healing sides of it too. So I think whatever it may be, there has to be a process in place that helps provide some sort of guideline or some sort of framework. And I know that organizations, not many of them, have these things in place. And I know this because I sit on a national workplace suicide prevention group, and a lot of people, a lot of workplaces don't even touch on these things. And it's not until, fortunately, I think for Judy's experiences and other organizations, sometimes you have a lot of people who die by suicide and still don't do anything about it. And it just boggles my mind sometimes of how losing somebody and having this happen doesn't result in some sort of change or some sort of process to try to meet the needs of what's happening. Again, though, too, why do you always have to be reactive? Why not be proactive? Why don't we have these things already in place for when it does happen, and we're not always just trying to react to, the situation in itself?
I think we talked a lot about a checklist, a checklist ahead of time that one person in the organization would be able to deploy. For us, it's our HERE counselors, the counselors that run our suicide prevention program. They have the checklist at hand. And it's like, can the chaplains help us with a memorial, organizing a memorial? Who will contact the family to see, if they're going to have a service, and do they want the hospital staff there, right? The healthcare staff there, or should we do our own thing, right? So there's a whole big list of things that need to be thought of and done, but having that list available in advance so that you don't have to think of it in the crisis is, I think what we're both saying is an important activity in the organization, figuring out who's in charge, who would know about these deaths routinely, right? And then who could deploy actions based on the role. So there's HR, there's the person's best friend at work, the manager, the chaplaincy program. If you have therapists or EAP, they're involved, right? And then go from there. One of the mistakes we make is limiting it to often these services or this discussion to only the unit where that person is working today, was working today, right? And the way that we work in healthcare, we're affected by people throughout the organization. So if you think of it, respiratory therapists come in and out of the ICU, and then they go to the wards. The EVS workers rotate around. You kind of got somebody you work with most of the time, but they kind of go around, right? The doctors come and go. So that if you only limit it to the small cadre of people in your one unit, you may be missing a lot of grieving souls out there. And the challenge is to get the message out that one amongst us has died, and the memorial will be available here, or we're going to have an emotional process debriefing on this date. Anybody welcome, right? Or whatever the choices are that you're going to deploy, and extend past that primary unit to make sure you're not leaving people out there grieving and unattended in their grief. Normalizing the idea of taking time off from work if you need it because you were that person's best friend and can no longer, you can't face coming into the unit where you used to work together right now. So normalizing the idea that people might need time off from work is another point on the checklist, and articulating it out loud so people don't have to wonder if they'd be supported in taking time off from work.
And when Judy talks about a checklist, there's actually, for the audience, they can actually look up, I think it's a manager's guide to postvention, suicide postvention. And I know that was created through partnerships, I think, with the United Suicide Survivors International and the National Action Alliance. But again, it's pointing out the where do we spend most of our work or time? Where do we spend most of our time? We spend most of our time at work, and we have to go to where the suicide prevention needs are the most, and we have to meet people where they are. And I think another one that's I've been actually honored to be involved with too is the Helping Our People Elevate Through Tough Times certification, or the HOPE certification. And this offers 9 pillars and 9 evidence-based interventions for healthcare organizations or organizations in general to embed mental health, comprehensive mental health, substance use, and suicide prevention efforts into their workplaces. And luckily, that's taken me quite a few places. So I'm actually writing some abstracts for Vienna for the International Association of Suicide Prevention World Congress. But I think, yeah, there's a dire need, I think, for it within the workplace, especially and within healthcare systems.
As we start drawing to a close, I want to ask you both. It seems that there's still quite a few mindset shifts that needs to happen within the culture of nursing and healthcare more generally that can really, just open up so much of the confusion or the misconceptions that remains around suicide. Judy, what mindset shifts do you believe is still very needed?
You'd have to repeat the question.
I was asking around what mindset shifts does there need to happen to change the culture of healthcare as it pertains to suicide?
Well, I think one of the big issues that we found with our research, as I mentioned at the beginning of this podcast, was about the problem with how do we deal with our colleagues who might have the treatable disease of substance use disorder. And I think we need a big mind shift on that topic because, if I look back, my friend, Dr. Marie Manthe, she and I did many of these talks together. At one point, she sadly died this year. Marie Manthe was a living legend in the Academy of Nurses, well known for her work with primary nursing and relationship-based care, and also an alcoholic. She described herself as a recovering alcoholic. She said, we need to stop looking at substance use disorder as a moral failure. This is a treatable healthcare condition. It is not a moral failure. Nurses with mental health disorders and mental health issues, nurses with mental health issues and substance use disorder need to be seen as nurses with treatable conditions. And that's, I think, the biggest mind shift that we have to make. Second is about the widget image. We are not widgets as nurses. We are not easily replaceable. You saw what happened in the pandemic when there weren't enough of us to provide care, when nurses walked from brick and mortar and went to the traveling agencies and crumbled the healthcare finances system, the system itself, because there weren't enough of us back in the brick and mortar systems. So we're not widgets. We are humans, and we need to work very diligently towards prevention of those workplace conditions that are attributing to suicide. So,
I recently heard a colleague say that maybe the biggest change we need to make is to stop speaking about health workers as human resources, because they're human assets.
Yep.
And we think people are resources, they're dispensable, they can just keep surviving.
Yes. We need to stop.
And that's a big shift.
Stop seeing nurses as nurses with mental health disorders as a risk to the organization. We need to see them as humans that are suffering, that have treatable conditions, right? So shifting this whole thing around. Yeah.
Chris, maybe a final question for you. I know you really believe that it's possible to be a clinician with lived experience and that you can face those personal struggles and still be totally capable of helping others. And could you maybe share as we end just how you've dedicated your life, your profession to doing that, and how you've been able to cultivate that approach to living in an empowered way? You used that word earlier.
Yeah, I think balancing my role as a clinician with lived experience, a husband, a father, is definitely something that I work at every day. I don't subscribe to the idea of work-life balance. That just doesn't work for me because it implies this perfect equilibrium that doesn't exist. For me, at least, that's just how I feel. So I tend to aim for work-life harmony, where I integrate my roles in a way that feels both fulfilling and rather than overwhelming. I know it's very easy to sometimes feel overwhelmed when trying to manage all the things that are going on. So my lived experience isn't a weakness for me. It's a strength that deepens my connection with the people I serve, with my colleagues. But to care for others, I have to care for myself, and I think that's one thing that is the toughest thing is setting boundaries and being intentional about family time and accepting that I won't always get it right. When I have an off day, I reflect, I adjust, and I move forward. After my daughter's suicide attempt, I realized that showing up emotionally is just as important as showing up physically. Our family has open conversations about mental health. I try to model what it means to seek help and practice self-care too. And that's why, my daughter and I, as I talked about a little bit before we started, that's why we're launching the Empowered Stories podcast. And that's a place where, my daughter and I will share our journey, offer some insights from different perspectives, and have meaningful, sometimes fun conversations. And, my work within my company that I started too, which, believe me, in nursing school, they never teach you anything about starting your own company, that's for sure. But I think my work at Empowered Psychiatric Solutions reflects the same mission, and that's we can equip nurses and healthcare workers with practical coping skills that aren't always taught, actually are never taught in school. Except for a few select universities. And I believe we can both be exceptional clinicians and present family members by prioritizing, for one, self-compassion, flexibility, purpose. And it's not about perfection. It's just about showing up fully in each moment. And I think those are the ways that I've been able to balance both lived experience with being a clinician.
Well, Judy, Chris, you started off this discussion by telling a little bit of the pain you experienced of either living through a suicide attempt or encountering people around you, and you've both turned that into great purpose, serving others. So thank you very much for being here and for being willing to share all your hard-earned expertise and knowledge.
No, thank you for inviting us and sharing this.
Thank you.
Thank you for taking the time to join us for this discussion. To learn more about our guests and to access the resources mentioned, please visit the Symptom Media Podcast page at symptommedia.com. We look forward to having you with us again for our next important conversation.